Good afternoon. My name is Alan Weil. I'm Editor-in-Chief of Health Affairs. We're the leading health policy journal in the United States, and we're pleased to be a partner with WISH in this event and prior years' events. Back in 2014, we published a full issue on advancing global health policy. There are some copies at the door. In this year, out of the prior WISH Summit, we compiled a selection of articles as well. Despite the fairly broad topic that's on the program, as a policy briefing, we are speaking about evidence-based policy solutions to address health challenges. The focus for the 45 minutes that we have together today is on universal health coverage. And we're going to have a time for a conversation with our two presenters, both of whom have written papers that have been published in our journal. I'll begin with some questions of them, and then, as we have in all of the other sessions, we'll open it up to you all for your participation. I don't want to take much of our limited time introducing the subject of universal health coverage. I suspect it's familiar to all of you. It comes up often in the context of the Sustainable Development Goal of ensuring healthy lives and promoting well-being. Universal health coverage is seen as a critical element of achieving that goal. Just a few minutes ago, we heard Julio Frank say, universal health coverage is nothing if it does not meet the needs of people. And what it turns out is that universal health coverage is a very important phrase to bring people together, but it leaves many questions unanswered around program design, around implementation, around the relationship of the health sector to the other sectors that affect people's health and well-being. And it's those questions and that context that leads us to publish articles in our journal and leads us to the conversation that we're going to have today. You'll be hearing from Ravi Rannan Aliya, the Executive Director of the Institute for Health Policy in Colombo, Sri Lanka. He's an author of a paper on the Malaysian health system, and you'll be hearing about that in a moment. You will also hear from Margaret Crook, an Associate Professor of Global Health at Harvard University's T.H. Chan School of Public Health in Boston, Massachusetts in the United States. Her paper is on a maternal health program in Uganda and Zambia, and she'll be discussing that program as well as the implications some of the lessons of that from that program have for design of universal health coverage. So I'm just going to begin, Ravi, with you and ask you to give a quick summary of the findings that you reported in your paper.
Sure, thank you, Alan. So let me just get it straight to it. Our paper is actually, it's not just my paper, it's a paper I did with colleagues in Sri Lanka and also in Malaysia in the Ministry of Health. And it basically an attempt to explore the universal health coverage performance of the Malaysian health system. Now, a couple of things just to note before I get to the main points. Malaysia is traditionally been very reluctant to share its data, so there's not much about Malaysia in a systematic sense in the literature. So I think this is really the first effort to do that in recent years. And we've been very lucky to have access to all the data the government had to do this. Now, what's unusual about Malaysia? Malaysia is well known in the literature as a country that's done very well in reducing maternal child mortality. That's the old MDGs. It's one of the best performers in the world over the past 50 years. It's not well studied with respect to UHC, which is one of the new goals. And what's unusual about Malaysia in a developmental sense is it's been developing fast. It's an upper middle income country. It aspires to become a high income nation in the next 2 decades or next decade. But it hasn't done the health system changes that developed countries have done. It's stuck with a very sort of developing country health system. It has very low levels of public spending, around 2% of GDP. And that's meant it's had high levels of private spending, around 1.5% of GDP. And this is despite its good MCH indicators. So what we did was we looked at how well it does on the UHC front. Turns out, and the bottom line is, it does extremely well, much better than other countries who are known to be good performers in UHC, like Thailand or Mexico or Turkey. In terms of healthcare equity, it has relatively good healthcare outcomes. Its IMR approaches that of the United States. It has relatively equal utilization of medical services, which is what we care about, if people get the services they want and need. It has very low levels of financial impoverishment. This is a kind of standard indicator of financial risk protection. In fact, the kind of bizarre finding was that although it has a relatively high share of private spending, its financial risk outcomes are akin to a country like Denmark or Sweden. Okay, and this is despite only having a public expenditure level of 2% of GDP. And its utilization levels approach that of, it's better than the US in terms of quantity, similar to that of the UK. So this is basically what we found, and then we explore how it achieves this. And the key thing here is it has a mixed system. It's neither NHS nor National Health Insurance System. It has a public sector which is available free, but people voluntarily, if they want, choose to use the private sector. So it's a mixed system, so we call it a hybrid between a free public sector system and a voluntary, out-of-pocket funded private sector.
Great. Before we go deeper into the Malaysia experience, Margaret, let me turn to you just so that everyone in the room understands the work that you published.
Sure, thank you very much, Alan. And if, with your permission, I also refer to another paper that an excellent postdoc of mine led, also in another issue of Health Affairs, because they're connected. The paper on the maternal health program that you referred to was a study of a large US government-led intervention to dramatically and rapidly transform the quality of maternal health care in Uganda and Zambia, in target districts of Uganda and Zambia. Why? It was to demonstrate that maternal mortality can be slashed in half, actually. The initial goal was to cut it in half in a year. So a huge, what we call the big push approach, was employed by the US government. And what we found in that paper, and when I say a big push, I really mean a big push. There were supply side interventions to improve quality in the two countries. There were many demand side interventions. By that I mean vouchers and education of the communities and involvement of change champions and radio advertising and all sorts of things to try to get folks to come forward to deliver in the health system. But one of the key findings in that paper was that although the two countries on paper followed the same big push model and had many health system improvements that they intended to do, it turns out that only Uganda really did much of the slate of things that they committed to doing for a whole variety of reasons that we don't have time to get into. But what this resulted in is our findings on quality were dramatically better for Uganda than they were for Zambia. So Zambia did a number of things that I think many of us in the room would say, hey, that should improve quality. They did additional training of providers. They stocked the facilities with drugs and equipment. But what Uganda did also is it hired new doctors. It actually introduced new services and higher level services, C-section, in a number of cases, in a number of settings. And introduced extremely detailed, meaningful supervision. And what we saw across a range of quality measures, and I'm glad, Alan, that you referred to Julio Frank's point about UHC has to show value to people to be relevant. Here, when we think about quality measurement, and I think we'll come to this, but quality is at the heart of universal health coverage. Quality also is a multidimensional construct. So when we looked at measuring it, we looked at it from the patient's view, from the provider's view, and also an objective observer. So in that study, we found that fundamentals, investing in fundamentals, investing in trained workers, matters. There weren't clear shortcuts because Zambia didn't do as well despite doing a number of those things. In the second paper that we published just recently in Health Affairs, we looked actually across a number of countries at a much narrower set of quality interventions. And they are two of the favorite interventions out there for improving quality. One is short trainings, continuing education, that our government, the US government, funds a huge amount of throughout the world. And secondly was supervision, another buzzword and hot topic in quality improvement. If we can supervise people, provide support, can we nudge that quality of care, that performance, clinical performance up? And what we found in that paper, looking at, again, a much narrower set of interventions, and the outcome that we measured was observations of clinical care quality. So someone in the corner of a room with a checklist looking to see whether the clinician does the right things for a sick child. We found that in that case, actually, turns out that training and supervision had only minimal effects on quality, something in the order of 2 additional correct clinical actions out of 18 or 40, depending on the service that we looked at. So what we saw there is extremely limited impact. And so you can kind of see the range. And I think what it does, I think these results do suggest many sort of policy directions, which I think we'll come to, but But a big one is that we do have to examine some of our favorite assumptions about what works.
So with those as a starting point, let's go a little deeper into the Malaysian experience. Ravi, in your paper you use the term pro-poor, and you describe the Malaysian system as more pro-poor than other Asian systems. I wonder if you can, you gave sort of the top line, but take us a little deeper into what it means and why it is you reach that conclusion.
So if you look at it on the surface, Malaysia's system looks pretty traditional. They have, it's not that much different to, say, Bangladesh. It has a, public sector which is more or less officially free, some minimal user charges, and pretty much anyone can go to public facilities and get their care. Now, most Asian countries, when you do this, those services end up being captured by the better off. In Malaysia, that's not the case. If you actually look, it's pro-poor in the sense that the bottom 50% of the population, the poorest 50%, accounts for 2/3 of the utilization of public sector facilities. That's pretty progressive. And in fact, it's probably the second best performance of any public sector in Asia. The only one we know that does better is Hong Kong, which is actually a similar kind of system. And on the private side, so people can go voluntarily to the private sector is predominantly used by the better off. So it's exact mirror image of the public sector. 50%, the richest 50% of the population uses 2/3 of all private sector care.
Now, the WHO is not particularly fond of high out-of-pocket spending, viewing that as a barrier to access, and yet you find high levels of financial protection in Malaysia despite that. Can you explain how that works?
Yeah, so just to give some background, the indicator that most people in the health policy community at the global level have been concerned about as a kind of what you'd look at when you're thinking about financial risk protection is the share of total spending that is out of pocket. And so there's a lot of literature, including WHO, saying we should reduce the level of out-of-pocket spending as a share of total to less than 25% or whatever. Now, Malaysia has a relatively high share, around 35-40%. It's been like that for a number of decades. And yet it has this very good financial risk protection outcome, as good as Sweden. So what's going on? It's turned out what we discovered was the share is not that important. What's really more critical, in a sense it doesn't really contradict the underlying concept or concern about out-of-pocket spending, is the actual level. So the actual level of out-of-pocket spending in Malaysia is only around 1% of GDP. That's the same as in Sweden. So it's not surprising that it has similar financial risk protection outcomes. The share is simply the ratio of that to the public spending, and that's where Malaysia doesn't do that well. It has low public spending. So the share is, I think, misleading, and what it suggests is it's really the out-of-pocket share as a share of GDP that should count. And if you can get away like the Malaysians with a low public spending level and ensure that most people have equal access to services of reasonable quality, then it's okay. I mean, that's what the Malaysians have done. They could do better, but they probably have to spend a lot more.
Okay. Margaret, I'm going to ask a few questions about your work. We focused this session on universal health coverage, but your papers that you described focus on programs, and I think they show the link between what you have to have in terms of a healthcare system to have an effective universal health coverage system. So I wonder if you could talk a little bit about another layer deeper in not just the nature of the interventions, but the context in which those interventions took place to see how that fits with a successful UHC model.
Sure. I think one, in a way, mistake that the global community has made in talking and thinking about universal health coverage is primarily as an insurance program. It's been, I think, described quite often as a way to pool resources, and that is certainly a very big piece of it, right? To reduce the financial harms that come from care seeking. But what I hear when there was an earlier panel in this room talking about why Thailand's been successful, for example, or why other countries have introduced universal health coverage have seen outcomes improve, health outcomes improve. And that's because they coupled the insurance element of UHC with real reforms in service delivery, right? Making services salient, meaningful, and of value to patients, to people, to communities. And so our work, I think, really builds on that, or builds that out, gives some specificity to this notion. Because one thing we're finding from even earlier work that looked at utilization and people's preferences is that even very, very poor people in very poor neighborhoods and countries will seek high quality services. And so imagine if in your country, universal health coverage is in place, is on paper, and what you have access to, what that coverage buys you, is access to a clinic, without a trained or competent clinician, without somebody who's going to treat you respectfully, and without the medicines that you need for your hypertension. That is meaningless to you. That is an empty promise. And I think that what we're seeing in our work is that when you're thinking about the quality of that universal health coverage package, that's got to be a core part of the measurement of success of universal health coverage. Because what we can see is a lot of coverage on paper, right? But also a lot of empty clinics being bypassed for the private sector. So I do think there is a direct relationship between the quality of care provision, the respectful care that's provided, and the actual use of those services, the financial protection that comes from those services, and ultimately the thing that every health system should be striving to do, which is to improve outcomes.
So Margaret, a moment ago you mentioned that quality is multidimensional, and both of your, the work that both of you have done brings the topic of quality in, but in somewhat different ways, and I'd like to try to bring those together. There's clinical quality, as in someone sitting in the exam room and determining whether or not appropriate care is being provided. But there's also Ravi used the term consumer quality, which is sort of what you might think of as amenities, convenience, hours, availability, cleanliness, which can have a clinical component, but may also just be a comfort component. Both of these are relevant, and I wondered if, again, if both of you, Ravi, starting with you, could talk about what measures you have of quality in the Malaysian system and how that speaks to the similarity or differences between the public and private systems.
So one of the things the Malaysians have done, and this is really a secret, they have low levels of public spending, but as Margaret's already mentioned, providing services is important. They provide everything in the public sector. You can get angioplasty, bypass surgery, Herceptin for free. There's some European countries you cannot get Herceptin for free in all parts of Europe. So they do all of that in the public sector. The clinical content is there, the full range, but what they've had to ration to afford this with 2% of GDP is they rationed consumer quality. So what don't you get in the public sector? You don't get a nice room. You don't get a TV when you go to the hospital. You don't get a private room. You don't get doctor choice. So they rationed on those kinds of things and basically figured out how to ensure that patients still get the medical treatment that they need. And the end result of that is poor people get the care they need. But better off people like me, people like you, basically everyone in this room, you won't like going to the public sector clinic, you won't like the hours, you won't like the convenience, and therefore you will go voluntarily off to the private sector and pay. And that's what rich and better off Malaysians do. So it's basically rationed quite implicitly or explicitly consumer quality to make the budget fit the actual demand.
And does that image fit with your work as well?
Absolutely, and we would call it non-technical or interpersonal quality, right? The technical piece, the medical competence, and then the non-technical piece, the responsiveness and the attention to the person as a consumer. For a while, my group has been doing research on preferences and using marketing techniques to find out what do people want when they go get healthcare. What is it they're looking for? And they're called stated preference experiments. And one of the consistent findings across a number of sub-Saharan African countries, which is where we've worked, is that, for example, for services that are really life cycle related, that are considered to be normal life events like delivery care, there's a massive value placed on this interpersonal quality, as well as the technical quality. In fact, they're about equally as important in people's decision about where to seek care. When it comes to emergency care, we see, for example, the interpersonal part mattering less, as you might expect it would, right? You want the most competent doctor when your child is very, very sick. So patients are actually extremely savvy, and people are extremely savvy about what it is they're looking for from the health system. So back to Ravi's example, and I think this very much echoes what we see. So first of all, if you're poor, you don't have choices. So you will try to do what you can. And in many places that are less well-resourced than Malaysia, often that decision is not to seek care, right? It's not to go to the nearest clinic. It's actually to avoid the health system and maybe seek a traditional provider or another source of care. But if you can possibly afford it, we see a lot of bypassing behavior where people are seeking better technical quality. But actually, it turns out that when women and men bypass to higher level clinics or private clinics, they report better care. Their perception is they got more value from that service. And I think we ignore this value to the population at our peril because, again, the UHC covered services will not be used, will not deliver the outcomes that we want without utilization.
So,
Yeah, I mean, just to follow on that, I mean, I want to just make reference to some work that we're also doing now in Malaysia, which is not yet published. This issue about the different demand for different types of quality is important. It also varies by income level. And you could say pretty much everyone wants to have the correct medicines or correct operation when you're sick. You want the doctors to diagnose you, give you that. But the demand for consumer quality, it's having a nice room, being in your own room or having a TV, these things are actually higher amongst higher income people, and they're more willing to pay for it. And so what the Malaysians have done is they shifted that demand to the private sector, whilst the poor people are probably reasonably happy because their expectations are much less on that front, because they get the basic clinical content, but they don't get that consumer quality. So in a sense, it's sort of matching the public supply to what the poor people want, but letting the private sector deal with the preferences of richer people.
so this sounds like a very complex political management challenge. You're trying to calibrate your public spending, which you have budgetary control over. You don't want it to shrink too much or the gap between, you lose the pro-poor. If it grows too much, you can't afford it. And then as a management issue within the public system, you have to get your managers to line up around the goals that meet the demands and needs of the poor, which is not typically who the political sector is most responsive to, knowing that those who have the means will buy their way out. How stable is this? What does it take to achieve that kind of balance?
So just on Malaysia, it's actually been incredibly stable. I mean, when we went into Malaysia to do this work, the government was very concerned about, the private sector is growing and blah, blah, blah. But it turned out there was an earlier study done by the World Bank in the early 1970s. And we could compare our findings from the late 2000s with those in mid-1970s. It turns out the public-private mix and the income gradients and the use of public-private services hasn't changed in almost half a century. I mean, it fluctuates. So when it goes up towards the private side, people get worried, and when it goes back the other way. Relatively stable. Now, what's going on in terms of political economy? I think the reason is, and why Malaysia has been able to do this, and a few other countries have done this with their public sectors, it's basically, I would say, one word: democracy. I mean, Malaysia, people might have questions about their political system, but basically it's had an accountable political system. Governments have had to face elections, and in the Malaysian context, it turns out their electoral system is heavily biased towards rural areas, which is sort of unusual. It's a bit like Japan, because rural constituencies are much smaller. So these governments have been incredibly sensitive to meeting the demands of poor people. Now, why does that matter? So on the issue of public spending and getting it right, if the public spending is too low, and that happens, then they'll get pressure back through the political system, and then they're forced to sort of adjust the level. So there's sort of a political economy calibration mechanism, I think, which has worked for 50 years because their political system is relatively stable.
What about the regulation on the private side? Does the private side just sort of keep to the right size just because it's counterbalanced against the public, or is there heavy regulatory role as well?
So Malaysia, and actually, as you mentioned, this is true also my country, Sri Lanka, and Hong Kong, which are very similar systems. Pretty much, I would say, the rule is laissez-faire. So basically in Malaysia, there's some minimal regulation, but as long as they don't kill people, they're pretty much allowed to do what they want. Now, how do they maintain clinical quality? Well, it turns out everyone's qualified in the private sector because they're all trained in the public sector. And I would say the public sector sort of provides a benchmark for what consumers or patients think is appropriate. So that's important. And then if the private sector prices go up too much, as they do occasionally, then people complain about the prices. They shift back to the public sector, or they get the politicians to raise public spending. So there's this sort of constant tension between the two sides, and I think it's sort of played out, but it's been relatively stable over time.
You know, and I think it's important to remember that Malaysia is a bit of an outlier, right, in discussing this. It's managed this and this really very interesting system that seems to have worked in terms of keeping catastrophic spending low, which I think is the main outcome that you're emphasizing. Many other countries have tried the same thing without such success. I think of the many countries in Latin America, for example, that have made tremendous strides in introducing universal health coverage, including Julio Frank's, of course, own experience in Mexico. And yet, in many of those countries, we see only very small declines in out-of-pocket spending and very large use and very pro-rich use of the public sector with many poor families. There are protests in Brazil as we speak on the quality of healthcare that people are getting. So I think there is something going on. Democracy might be part of it. I think Mexico was also democratic, and some are other countries. I think there's another element to consider in making this work. And you know, there may be a social cohesion element that isn't completely captured by just the word democracy. But another one, certainly, that I've heard about from Julio and others is that, you know, part of the reason that universal health coverage works well in some parts of Mexico and less well in others is, frankly, implementation capacity and governance at the decentralized level. Malaysia is a fairly centralized country. When you take UHC to a much, you know, a larger, more decentralized, more sort of chaotic environment, or in environments with much lower implementation capacity, I think there you struggle. Also including, for example, in regulation of the private sector, and all sorts of things happen. We see those results from India, for example, where 80% of NCD care is provided by the private sector, but they're completely unregulated, really. So I think, I mean, it's a very interesting example, and certainly one to learn from. I do wonder whether the wonderful achievements of a few countries like Malaysia, and in fact Sri Lanka is even a better example because it's done at an even lower cost, are generalizable, and if not, why not?
So before I turn to you, I also want to map this issue to your study and note that Uganda and Zambia were selected because of commitment, in government commitment. You have different results in the two countries. Right. You just referred to implementation capacity, political will. Is that a factor as well?
No question. So both countries, the US government partnered with those two countries because they had, you know, a already drafted maternal strategy. They were eager to get going. They really wanted to the MDGs, by the way, were a very powerful unifying force and motivating force. And yet, you know, in Uganda, there were more. I think one of the findings we had was that, frankly, the next level below the leadership level, there were just more people invested in making this program work. There were more line managers, more district officers. You know, there was just a different level of competence and ability to deliver. And frankly, the US partners also bear some responsibility because the ability to deliver, for instance, one difference was Uganda's districts were contiguous. So it was much easier for the US partners to invest in contiguous districts, to share best practices and so on, whereas Zambia deliberately chose, you know, very remote districts in different parts of the country. So again, implementation was tough. You know, I always say implementation is easy in the capital city and its surrounding area, you know, and that isn't the trick, that isn't the challenge that we're solving for. So I think we do have to consider implementation as one really important success factor.
Did you want to comment on?
Yeah, I mean, just a common observation on that. I mean, I think the issue of democracy is fairly complex here. I mean, I think if I take Latin America, the historically good performers, and you know, Latin America has generally done bad on being pro-poor, shall we say, in terms of reach. But who are the good performers? Well, there's Cuba, you know, Fidel Castro just died this week. But there's also Costa Rica. And then there's the Anglophone Caribbean states, all of which were democratic for very long periods of time. And if you look in Asia, Sri Lanka is the oldest democracy in Asia. Malaysia and Singapore are essentially the oldest democratic states in Southeast Asia. And it's the length of time that they've been democratic. So they've had political economies which have forced accountability in an organic way. And they've been able to achieve this success, I think, without having any kind of notable champions. So there's no Thaksin in Malaysia, right, that we can associate with UHC. There's no Julio Frank or whatever. There's no kind of big name that you can say, well, that's the person who did it. All these countries, they just had a general system of accountability, and then this just came out. The other countries, and Cuba, I think Cuba is another example of this, they weren't necessarily democratic, but they then needed some other way of getting those kind of transformations, and it was much more dependent on ideology and I think personality and individual regimes. But in these other cases, no one in particular. The system just sort of ensured that governments were accountable.
I have a number more questions I'd like to ask, and I'm definitely going to save at least one for the end, but I do want to make sure that those of you who've come have a chance to engage as well. We have microphones, and I think it would be helpful to capture by mic. So if you can get one to the gentleman right here in this, the most difficult spot to reach. Well, I think it's best to, can you bring one down here, please? And then, and please introduce yourself as you ask a question. Thank you.
Abdul Badi Abu Samra, Chairman of Medicine here at Hamad Medical Corporation. Question about Malaysia seemed like a very interesting system. So first, what is the percentage of care provided in the private and public, in terms of in Malaysia? And second, you mentioned consumer quality, but how about the clinical quality? Are they comparable between the private and the the public sectors?
So just in terms of quantity, I mean, it's in the paper, but there wasn't much time to explain all the details. So in terms of quantity of care, about 75–80% of inpatient care is public, and the rest is private. And in terms of outpatient care, the recent figures for 2015, it's about, I think, 55–60% public now. It was about 50% 10 years ago, and the rest is private. So it's about 50–50 on the outpatient side, but predominantly public on the inpatient. Now, in terms of clinical quality, this is one of the things in the paper at the end. We say, well, we think this is a really good model. They appear to be sacrificing consumer quality, but we think they might be doing okay on clinical. But we don't have any data. But actually, there is some work which we've done since. We hope to publish in the next year, which use data from Malaysia to look at clinical quality in the public and private sectors using very large data sets. And what we surprisingly found was clinical quality was actually slightly better. It was highly statistically significant, better in the public sector clinics than private. And we think that if we're going to do work on the inpatient side, we'll find similar on the inpatient side. So they spend less, but get better clinical quality.
I see two in the back, one right on the aisle, and then we'll move in from the aisle.
Thank you very much. Robert Yates from Chatham House. Just to address this issue of the sustainability of these models of a publicly financed system covering the masses and the rich self-selecting out. I think there's plenty of evidence how robust these systems are. I mean, you look at even the UK and the NHS, where the financing goes up and down, and a government that is seen not to fund the NHS properly will tend to get sort of booted out after a while, and the new government will come in and ramp up the public financing. And I think also Thailand is another good example of this, where sort of Thaksin obviously brought in the big UC scheme that was very much associated with him, but when the military government took over, they actually increased the financing for the UC scheme and got rid of the co-payment. So I think that these systems, once they're embedded in a democracy, are actually very robust to political changes, so which is very good news for their long-term sustainability, really.
Yes.
Ravi, I'd be interested in your take on the particular aspect of clinical quality of overuse. So we've seen in these sort of laissez-faire private settings in Tamil Nadu and Kerala and Nepal and in Brazil, increases in cesarean section rates as a sort of a paradigmatic case of overuse, and one that sort of is mutually reinforcing because of repeat cesarean being a major cause of indication for cesarean, and then also antibiotic overuse. So I'm just curious, in your in the Malaysian context, have there been much of analysis of this clinical quality aspect of overuse?
So that's not in this paper, but as I said, we have done work since, and for various reasons we could not cite it in the paper because it was still not published. But basically, just to give you an idea, just to show what we did, the Malaysians happen to have some large data sets where they sample public and private patients in the outpatient primary care side every 1 or 2 years, talking about tens of thousands of patients each time. And we used the methods that the RAND Institute has developed in the US to assess quality of care in the US, so it's clinical quality of care. And those indicators measure whether doctors do the right thing or whether they don't do the wrong thing. So it could be like overuse of medication. So that would be, if they do the wrong thing, that would also be a quality indicator. And so we have a mixture of both of those kinds of indicators, excess use and underuse. And on those indicators, the public sector was doing better than private. And it turned out, we've only done a limited comparison with the US. They were comparable for the kinds of care they were giving with the United States. There's some studies from the VA some years back. They were comparable with that. And we also had some data from Australia suggesting for most things, quality is comparable with Australia. Where quality is worse, and I'll be honest about this, is the high-end stuff. So if you have a heart attack, you're not going to get necessarily the high-end, angiograms immediately and all this kind of stuff. But on the low to middle intensity stuff, they're doing as well as a developed country. That's the unpublished data. That's what it suggests.
So I'm going to close with 2 questions so that we're sure that you all can get to the reception before they close the doors there. We have a little overlapping timing going on. I want to first ask both of you about the social context. If the goal is to improve health and well-being, we know that most of the causes of health and well-being arise from outside of direct clinical care. A topic here at WISH this year and last year is accountable care and the ability to sort of create systems that bring these elements together. I wonder if from the 2 very different models that you looked at or interventions that you looked at, you could talk for a moment about the implications of the system or the interventions that you studied for the ability to move to a more integrated social health approach to improving care or an accountable care model. That's maybe not where you were thinking we would go next, but I do think it's a move with global implications. It'd be interesting to hear your thoughts. Who wants to take that first?
No, I think that's a great question. I think the idea that the health system bears accountability, bears its share of accountability for the health of its population is, in some ways beyond basic, and yet I don't think that is how health system planners or managers or even providers think. They think of patients as units, individuals who will do what they're going to do, and often don't think of their role in the health equation. So I actually do find that sort of accountable care thinking is actually quite applicable in countries of all income levels. I think the idea that one of the things we're interested in measuring, for example, is, can you link district level quality to newborn mortality outcomes? I mean, they should be responsible because actually good quality care during childbirth is one of the large major determinants of survival for little babies. And so our health system as a whole should be accountable for some of those outcomes. And in other outcomes where the patient or the co-production is a larger factor, it's still important, in terms of reaching out into the community, bringing the community in, being more responsive. We mentioned convenience, we mentioned TVs. I just want to say even the very basic elements, forget TVs. In the countries where I work, that's not the consumer quality or that's not the non-technical thing that matters. What matters is that the clinic is open after 3 o'clock, or that there will actually be somebody with knowledge of your condition there. Just somebody who will listen, hear you out, versus spending the 8 minutes a visit that we documented or spent. So the very basic accountability to the population, the ability to reach the population, and then fundamentally to be able to answer for why outcomes are not better.
I mean, that's actually a good question, and it sort of actually points me towards some of the downsides of the Malaysian system. Maybe I should just mention that. So Malaysia does well on most of these measures, but where they have two particular problems. One is that the middle income people they don't like the convenience, there's lack of convenience into access or other things, and they go to the private sector and they don't like paying the money. So they sort of grumble, and there's a constant political pressure on government to solve this problem of having to pay out of pocket by essentially, I would say, upper middle income people. The rich people don't care, they can pay. The other problem is that the integration issue in terms of clinical integration is very problematic, particularly in primary care. I mean, if you live in a city in Malaysia, basically 60% of all those outpatient primary care stuff is in the private sector, outside the site and outside the control of the public sector. So, you can talk about gatekeeping as much as you want, you can talk about sensible referral systems, pathways. It doesn't work very well when you essentially have two complete disconnected sectors and people can do what they want because it's freedom of choice. Now, I would actually say that these are problems all these systems like Malaysia have. I actually don't see any easy solutions, because really the only way they can solve this is to integrate the financing, and the reason Malaysia has this system is because the government doesn't want to spend a lot more money. It didn't do what the British did in 1948, increase spending substantially and bring in the GPs, the private doctors, into the public financing scheme. So they're sort of stuck in this situation. It has a political price, but unless the government, I think, is willing to pay the political price of raising taxation or other forms of public funding, it's sort of stuck with this sort of things are not quite right at the boundary or at the edges.
So I'll just close with a fairly broad policy question. Your work focuses on the countries it focuses on. They have their unique characteristics. It's always risky to generalize, but these are very important findings. If you were to give the audience some advice or lessons that you've learned about designing universal health coverage, what would they be? I'll start with you, Ravi.
So I think the simple message from Malaysia that I think would like everyone to know is this: look, if you want to do UHC in developing countries, everyone knows what you have to do technically, right? And I think that everyone would agree with increased public spending, improve access to care, improve financial risk protection, but all these things cost more public money. And whether we like it or not, and whether I like it or not, in many poorer countries, governments either are not willing, for whatever reason, or not able to spend that extra public money. And what Malaysia provides is an example of how you can do as well or better than, say, Mexico or Thailand, and get away with doing that with only 2% public expenditure. So Malaysia is really an example of one option, if you could replicate what they're doing, of how to move towards UHC if you can't get over the public financing barrier. So it's sort of it's another route. It doesn't solve all the problems, but it's a solution for those countries.
Very good. Margaret.
Yeah, so I think my one piece of advice on universal health coverage would be to pay attention to the fit. By that I mean the fit between what the health system is capable and funded to do and its goals to improve, hopefully, population health, and what the population on the other side expects, what people expect. Because if you don't get that right, you're at worst or minimum wasting money, and potentially you're wasting lives. So I think this idea of understanding what people want and demand, and by the way, we've talked a lot in this meeting, I've already noticed about the kind of endless demands of people, but it turns out, I think when you talk to people do understand constraints, and their expectations are tempered by what they can be made to understand their country can spend. So I think having those conversations and getting the information about what the population values most is critical. And then let's set up a system that can meet that and not the other way around.
Very good. Well, I hope you've enjoyed this conversation. Feel free to pick up the materials that we have, and please join me in thanking Ravi and Margaret for their excellent presentations.